Good morning, ladies and gentlemen. I am Dr. Armen, Astvatsatryan, professor from Yerevan, Armenia. So for you, I am Dr. Y. And today we will talk about, my dear students and friends, about wheezing. So wheezing is a relatively high-pitched whistling noise. So wheezing is a relatively high-pitched whistling noise produced by movement of air through narrowed or compressed small airways. It's a symptom as well as a physical finding. About pathophysiology, but before pathophysiology, could we hear this sound? Actually, you can find sound of wheezing in my auscultation video. I give you a link, okay, auscultation. Or you can find in my videos several lectures concerning auscultations with presentation. Anyway, now let's hear wheezing, okay? Yes, please. Very obvious, right? Once again. And the last time. Thanks a lot. Now we continue. Pathophysiology of wheezing. Pathophysiology. So airflow through a narrowed or compressed of a small airway becomes turbulent, causing vibration of airway walls. This vibration produces the sound of wheezing. Wheezing is more common during expiration because increased intrathoracic pressure during this phase narrows the airways, and airways narrow as lung volume decreases. And wheezing during expiration alone indicates milder obstruction than wheezing during both inspiration and expiration, which suggests more severe, of course, airway narrowing. By contrast, turbulent flow of air through a narrowed segment of the large extrathoracic airways produced a whistling inspiratory noise. Inspiratory noise is a stridor. Okay, we talked about stridor. I give you a link. So, etiology of wheezing. Small airway narrowing. Small airway narrowing may be caused by bronchoconstriction, mucosal edema, or external compression or partial obstruction by a tumor, foreign body, or thick secretions. Overall, the most common causes are asthma, chronic obstructive pulmonary disease, COPD. But wheezing may occur in other disorders affecting the small airways, including heart failure. We talked about heart failure. We've got several lectures. I give you a link. Okay. So including heart failure, allergic reactions, including anaphylaxis and toxic inhalation. Sometimes healthy patients manifest wheezing during a bout of acute bronchitis. In children, bronchitis. In children, bronchiolitis and foreign body aspiration are also causes. Okay, so once again, sometimes healthy patients manifest wheezing during a bout of acute bronchitis. Yeah, so in children, bronchiolitis and foreign body aspiration are also causes. So why not to talk about some causes? Let's talk about causes of wheezing. Causes, yeah. Okay, so acute bronchitis cause, suggesting findings, URI symptoms, infection symptoms, and no known history of lung disease. And diagnostic approach, clinical evaluation, of course. Another cause is allergic reaction, suggestive findings, sudden onset, usually within 30 minutes of exposure to known or potential allergen, often nasal congestion, urticaria, itchiasis, sneezing, and diagnostic approach, clinical evaluation, of course. Asthma, often known history of asthma, wheezing arising spontaneously or after exposure to specific stimuli, for example, allergen, infection, upper respiratory infection, cold, exercise, and clinical evaluation is a diagnostic approach. Sometimes pulmonary function testing, peak flow measurement, metacholine challenge, or observation of response to empiric bronchodilators. Bronchiolitis, another cause of wheezing in children less than 18 months, usually from November to April in the northern hemisphere. Usually URI symptoms, upper respiratory infection symptoms, and tachypnea. Diagnostic approach is a clinical evaluation. COPD, exacerbation as a cause of wheezing in middle-aged or older patients, suggesting findings, often known history of COPD, so anamnesis. Extensive smoking history, smoking history, poor breath sounds, dyspnea, pursed lip breathing, and use of accessory muscles. Diagnostic approach, of course. Clinical evaluation sometimes checks X-ray and ABG measurement. Some drugs can cause wheezing, for example, ACE inhibitors, aspirin, beta blockers, non-steroid anti-inflammatory drugs, suggesting findings, recent initiation of any drug, most often in a patient with a history of reactive airway disease, and diagnostic approach is a clinical evaluation. Another cause of wheezing is endobronchial tumors, fixed and constant inspiratory and expiratory wheezes, especially in a patient with the risk factors for or signs of cancer, for example, smoking, history, night sweats, weight loss, hemoptysis. May be focal rather than diffuse. Diagnostic approach, chest X-ray or ST broncho or computer tomography, bronchoscopy, usually preceded by spirometry with flow volume loops that indicate obstruction. Another cause of wheezing is a foreign body. Suggestive findings, sudden onset in a young child who has no URI or constitutional symptoms. Diagnostic approach, chest X-ray and bronchoscopy. GERD with chronic aspiration, reflux, chronic or recurrent wheezing, often with heartburn and nocturnal cough. No URI or allergic symptoms. Diagnostic approach, trial of acid suppressing drugs, sometimes esophageal pH monitoring. Inhaled irritants can cause wheezing, sudden onset after occupational exposure or inappropriate use of cleaning agents is a suggestive finding, and diagnostic approach is a clinical evaluation. Another cause is left-sided heart failure with pulmonary edema, so-called cardiac asthma. Suggestive findings for this pulmonary edema. Crackles and signs of central or peripheral volume overload, for example, distended neck veins, peripheral edema, dyspnea while lying flat, orthopnea, so classic heart failure, or appealing 1-2 hours after falling asleep, paroxysmal nocturnal dyspnea. Diagnostic approach, chest X-ray, ECG, blood pressure, BNP measurement, echocardiography. Evaluation of wheezing. When patients are in significant respiratory distress, evaluation and treatment proceeded at the same time. History of present illness. No, history, of course, we start with history. History of present illness should determine whether the wheezing is new or recurrent. If recurrent, patients are asked the previous diagnosis and whether current symptoms are different in nature or severity. Particularly when the diagnosis is unclear, the acuity of onset, for example, abrupt or gradual, temporal patterns, for example, persistent versus intermittent, seasonal variations, and provoking or exacerbating factors, for example, current upper respiratory infection, allergen exposure, cold air, exercise, feeding in infants are noted. Important associated symptoms include shortness of breath, fever, cough, and sputum production. Review of symptoms should seek symptoms and signs of causative disorders, including fever, sore throat, the rhinorrhea, respiratory infection, orthopnea, paroxysmal nocturnal dyspnea, and peripheral edema, heart failure. Night sweats, weight loss, and fatigue, cancer, nasal congestion, itching eyes, sneezing and rash, allergic reaction, and vomiting, heartburn, and swallowing difficulties, gastroesophageal reflux disease with aspiration. Past medical history should ask about conditions known to cause wheezing, particularly asthma, COPD, and heart failure. Sometimes the patient's sometimes the patient's drug list may be the only indications of such diagnosis. For example, inhaled bronchodilators and corticosteroids in COPD, diuretics and angiotensin converting enzyme inhibitor in heart failure. Patients with known disease should be asked about indicators of disease severity, such as previous hospitalization, intubation, or intensive care unit admission. Also, conditions that predispose to heart failure are identified, including atherosclerotic or congenital heart disease and hypertension. Smoking history and exposure to secondhand smoke. Secondhand smoke should be noted. Physical examination. Secondhand is a passive smoking. Physical examination. Vital signs are reviewed for presence of fever, tachycardia, tachypnea, and low oxygen saturation. Any signs of respiratory distress, for example, accessory muscle use, intercostal reaction, pursed lip breathing, agitation, cyanosis, decreased level of consciousness, should be immediately noted. Examination focuses on the lungs, particularly adequacy of air entry and exit, symmetry of breath sounds, and localizing of wheezing, diffuse versus localized, inspiratory, expiratory, or both. Any signs of consolidation, for example, agophony, dullness, or percussion, or crackles should be noted. The cardiac examination should focus on findings that might indicate heart failure. Such murmurs, a third heart sound, S3 gallop, and jugular venous distension. The nose and throat examinations should note appearance of the nasal mucosa, for example, color, congestion, swelling of the face of tongue, and signs of rhinitis, sinusitis, or nasal polyps. Okay, so signs of rhinitis, sinusitis, or nasal polyps. The extremities are examined for clubbing and edema, and the skin is examined for signs of allergic reactions, for example, urticaria, rash or atopy, for example, eczema. The patient's general appearance is noted for constitutional signs such as the cachexia and the barrel chest or severe COPD. So the red flags, the following findings are of particular concern: accessory muscle use, clinical signs of tiring or decreased level of consciousness, fixed expiratory and expiratory wheezing, swelling of the face and tongue, angioedema. So interpretation of findings. So, okay, sorry, interpretation of findings. Recurrent wheezing in a patient with a known history of disorders such as asthma, COPD, and heart failure is usually presumed to represent an exacerbation. In patients who have both lung and heart disease, manifestations may be similar. For example, neck vein distension and peripheral edema in cor pulmonale due to COPD and in heart failure. And the exact etiology is often hard to determine. When the cause is known, asthma or COPD, history of cough, postnasal drip, or exposure to allergens or to toxic or irritant gases, for example, cold air, dust, tobacco smoke, perfumes, may suggest a trigger. Clinical findings help suggest a cause of wheezing in patients without a known history. Acute sudden onset wheezing is in the absence of symptoms of an upper respiratory infection, suggests an allergic reaction or impending anaphylaxis, especially if urticaria or angioedema is present. Fever and infection symptoms suggest infection, of course. Acute bronchitis in older children and adults, and bronchiolitis in children less than 2 years. Crackles, distant neck veins, and peripheral edema suggest heart failure. Association of wheezing and with feeding or vomiting in infants can be a result of gastroesophageal reflux. Patients with asthma usually have paroxysmal or intermittent bouts of acute wheezing. Patients with asthma, yes, usually have paroxysmal or intermittent bouts of acute wheezing, yeah. And persistent localized wheezing suggests focal bronchial obstruction by a tumor or foreign body. Persistent wheezing manifesting very early in life suggests a congenital or structural abnormality. Persistent wheezing with sudden onset is consistent with foreign body aspiration, whereas the slowly progressive onset of wheezing may be a sign of extraluminal bronchial compression by a growing tumor or lymph node. So testing seeks to assess severity, determine, diagnose, and identifying complications. Pulse oximetry, chest X-ray, if diagnosis unclear, sometimes arterial blood gas, ABG measurement, sometimes pulmonary function testing. Severity is assessed by pulse oximetry and in patients with respiratory distress or clinical signs of tiring, ABG testing. Patients known to have asthma usually have bedside peak flow measurements. Patients with new onset or undiagnosed persistent wheezing should have a chest X-ray. X-ray can be deferred in patients with asthma who are having atypical exacerbations and in patients having an obvious allergic reaction. Cardiomegaly, pleural effusion, and fluid in the major fissure suggest heart failure. Hyperinflation and hyperlucency suggest COPD. Segmental or subsegmental atelectasis or infiltrate suggest an obstructing endobronchial lesion. Radiopacity in the airways or focal areas of hyperinflation suggest a foreign body. If the diagnosis is unclear in patients with recurrent wheezing, pulmonary function testing can confirm airflow limitations and quantity, its reversibility and severity. Metacholine challenge testing and exercise testing can confirm airway hyperreactivity in patients for whom the diagnosis of asthma is in question. Okay, treatment of wheezing. Definitive treatment of wheezing is treatment of underlying disorders. Wheezing itself can be relieved with inhaled bronchodilators, for example, albuterol. Long-term control of persistent asthmatic wheezing may require inhaled corticosteroids, long-acting beta-agonists, leukotriene inhibitors, or other therapies. Intravenous H2 blockers, diphenhydramine, corticosteroids, methylprednisolone, subcutaneous and inhaled racemic epinephrine are indicated in cases of anaphylaxis. Okay, key points. Asthma is the most common cause, but not all wheezing is asthma. Not all wheezing is asthma. Acute onset of wheezing in patients without lung disorder may be due to aspiration, allergic reaction, or heart failure. Receive airway disease can be confirmed via spirometry. Inhaled bronchodilators are the mainstay of acute treatment, my friends. So that's all concerning wheezing, my friends. Thanks for your attention. And once again, don't forget, please, to make your donations to our channel, because without your donations, our channel will be closed. We can't exist, actually. It's no joke. Huh? So thanks in advance for your donations. Don't forget to follow and subscribe. If you're in YouTube, put the ring on also to be in touch with all the news, with all news from our channel, Dr. Y. And if you are in, I don't know, cast, our cast, Dr. Y's cast, so just make your subscription and donations, of course. Without donations, once again, we will be closed. So once again, thanks for your attention, and God bless you. See you in the next lectures. Bye.